This video is in fulfillment of my reflective journal entry for active labor in labor, birth, and IPP. So what I have reflected on after our case studies, which goes over basically the differences in what active labor might look like or the midwife's approach when it comes to primips, multips, and grand multips. I feel like I've been with a lot of primips lately, and the biggest thing that I notice, primips typically in the practice that I'm at, they don't want to be checked as often as multips. They see those changes in their body that they're more aware of because they've done it before. And so they're like, yeah, check me because I'm pretty sure I'm past 6 centimeters, you know? Where the primips are like, I have no clue what's going on in my body, what I'm feeling, is this making progress? You know, but don't check me because I don't want your hands inside my body because this is all uncomfortable. So then assessing where they're at can be really difficult, and we use Mobile Midwife for charting. And so while we're charting, we're charting whether this is early labor or active labor. And then some parents really surprise us because I'm charting and I'm just like, this is early, this is early, this is early, you know, every half hour. And then it's like they switch over really fast, and it's like there's maybe like an hour of what I have charted as active labor until this client is, you know, pushing and actively delivering their baby. So I feel like that it's harder to gauge with the primips where they are, like just visually assessing them when you're not able to do a vaginal exam. And then with multips, I feel like there are more signs of active labor and that their bodies kind of know what to do and give us signals like we're going to see bloody show and loose bowels. And they're going to be making different noises that sometimes, sorry, excuse the dogs playing in the background, that differ from primips, maybe have more control, you know, maybe are like a little more screamy. Whereas with the multips, they kind of know more how to relax their bodies, and then you notice their sounds changing and, you know, their moans changing in their quiet times in between contractions, and then when they're not quiet anymore. So when it comes to primips and multips, I feel like there's just big differences that I have observed in the 50 plus births that I've been to so far. And they just vary person to person and their style. We also talked about the quiet ones, and those are always the ones that scare me, that just don't make any noise throughout labor. And then you just never know what's happening with their body because it's like they're just quiet, 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 and then you hear a grunt and it's like, oh shoot, this baby's coming out right now. No warning. The quiet ones always get me. Anyway, and then when it comes to support in labor and when things are getting active, it depends on what the parent's preference is, but I like to get people up and get them moving, maybe walking around the room, walking around the facility if we're at the birth center, or around their house, helping them to relax yet still move their body and get that baby like really engaged and moving down. The dilation station at the toilet is always a good idea, especially if people seem to be stuck at a certain spot. In class, we talked about artificial rupture of membranes and when we would do that and when we wouldn't. I agreed with most of the class where with our primip client, which was case number 1, at 6 centimeters, I would not be inclined to break her water because it could still be, another 12 hours, or it could be really quick. She could surprise us. But having confidence in your body, especially when it's your first go round, is really important in teaching that client that their body knows what's right and that their water is going to break when it's meant to break, which could be just during pushing. Whereas for our third case study, or not the third, it was the second, which was our multip parent, and she was at 8 centimeters. And if she wanted her water broken and we did it, she could have her baby within 15 minutes, and depending on her experiences in the past and breaking her water, she might request that, or she might choose not to, but that would be something that I would be more inclined to do with somebody who is progressing a little bit further and it isn't their first baby. So evidence suggests from our study this week on artificial rupture of membranes that it's best to do, there's better outcomes when you do it later in labor versus earlier in labor. It doesn't necessarily cause labor to be shortened at all. And there's more risk of infection, of course, with PRIMIPs, and you don't know how long their labor is going to be. It could be drag on for a long, long time, and then you've exposed this parent to a risk of infection that we don't really want to do. So it depends on clients' wishes and what the whole situation, the whole picture looks like. So that sums up my reflection for active labor and managing what I would do in that situation.